Welcome everyone. Thank you for attending Health IT Usability, helping physicians work faster and smarter, the third in our HIT Usability webinar series. If you are unable to attend our first two presentations, I will be emailing everyone after this presentation with on-demand viewing instructions for all of the presentations. Before we introduce our presenter, I'd like to share a little bit about User-centric. We are a global user experience research and design firm based in Chicago. We've applied our expertise to projects involving handheld devices, websites, software, medical devices, print packaging, and telephone services. To learn more about User-centric and our services, please visit usercentric.com. I'm excited to introduce today's presenter, Dr. David Leibovitz. Dr. Leibovitz is a practicing internist and the Chief Medical Information Officer for the Northwestern Medical Faculty Foundation, the full-time academic medical practice affiliated with the Feinberg School of Medicine at Northwestern University. In this role, he works to advance development of the outpatient medical record system and optimize information exchange with Northwestern Memorial Hospital, where he also serves as Medical Director for Clinical Information Systems. Within the hospital, Dr. Leibovitz is the physician leader for initial implementation and now optimization of CPOE and online documentation. Northwestern Memorial Hospital has successfully adopted online physician entry of orders and notes for all inpatient services and has entered its maintenance phase, in which Dr. Leibovitz is now working to complement existing basic decision support with advanced and anticipatory enhancements for high-risk areas. Leveraging this experience, Dr. Leibovitz is a program director and course instructor for the Northwestern University Masters in Medical Informatics program. In addition, Dr. Leibovitz is participating on several funded research projects, works 6 weeks on the inpatient general medical service, sees outpatients in his clinical practice, and supervises residents' inpatient and outpatient clinical experiences. Prior to his current 5 years at Northwestern University, Dr. Leibovitz worked as a full-time faculty member at the University of Chicago, received his medical degree at the University of Illinois at Chicago, and his undergraduate degree in electrical engineering at the University of Illinois in Urbana-Champaign. Welcome, Dr. Leibovitz, and thank you for presenting with us today. Throughout the presentation, if you have questions, please submit them through the GoToMeeting application, and we'll plan to address as many as we can at the end of the presentation. Welcome, Dr. Leibovitz.
Great, thank you very much, Shelley, and thank you very much, User-centric, for having the opportunity to share some of my thoughts based on the real-world experiences that we're having at Northwestern, as well as even dating back to my time at the University of Chicago with electronic medical record use at that location. So to begin, I'd just like to outline a few themes that will be present throughout today's presentation. And these include clearly patient safety, something that is uppermost in our minds at all times. Patients who see physicians regularly now tend to have multiple medical problems that are being treated with an array of medications that were not even available not so long ago. Physician efficiency, while the patients we're seeing have increased complexity and the available treatment modalities have increased, these, in the context of patient care, have led to often numerous steps that may ultimately impair physician efficiency, cause more interruptions, also impacting as well patient safety. And then I'll talk about reporting, which will be another theme throughout the slides today. We want to see the data, see the effectiveness of what it is that we're achieving here. So first, I'd like to bring in a quick poll. And so they can see the poll now. And we'd like everyone to respond to select what your current role is. Give you a couple more seconds. Most people have had a chance to respond. we show the poll results? Oh, this is what we're doing. So you can see, even though I'm giving the presentation today, we probably have a number of experts on this call who have very important opinions and more in-depth experience on usability. I'm giving pretty much a focus today that you'll see from a practicing clinician's experience who's had at least a good number of years working on these topics from the at-the-bedside clinical user's perspective. So let's jump back to the slides here for a moment. What does the doctor really want? So the doctor is very interested in being faster at what they do, so putting it into the doctor's words. Doctor wants to be smarter than he otherwise might be with help from an electronic health record that's effectively, efficiently, and safely designed. And a physician wants to then be able to review the information that shows how the system is actually helping them perform faster, more effectively, and then be able to leverage this information in a patient care and research context. So let's delve in a little bit more into the make me faster context. So one of the attributes that I struggle with on a day-to-day issue, both from our electronic health records, plural, that we have here at our Northwestern campus, as well as interacting with other electronic medical record systems, is that in most instances, they're not leading us along in terms of what a physician might want to do next. So, however, this isn't necessarily as complex as one might think. So in terms of making me faster, if an electronic health record effectively anticipated next steps, there's really only a few categories of actions that a doctor undertakes when they're interacting with an electronic medical record. They are either reviewing or updating old content, and this relates to results, notes, continuity of care record content. So a doctor might be looking at a chart just to really see what exists there, review, have a specific question in mind and wants to identify that information and then update. Or a physician may need to enter an order for a patient, or write a note, or attempt to communicate with others. Beyond that, there really isn't much else that a physician does when he or she is interacting with an electronic medical record system. One thing to keep in mind, however, is that any of these actions can occur juxtaposed to any of the other actions. So in the process of creating a note, one may wish to communicate, one may realize that there are orders to be entered, or there may be additional historical information that may need to be reviewed. Being able to retain this context and achieve these functions is something that truly is required in order to operate more effectively. And I'll talk a little bit more about that as well. Similarly, there's certain steps and actions that physicians follow on a regular basis. And why a physician has to go through a few steps to find it out is to just do something that they've been accustomed to doing doesn't make sense. The system should kind of learn preferred modes of behavior for specific physicians. And I'm aware that a few of the electronic medical records companies are just starting to do this. A number haven't. The example that often one can look to is the cascading menus in Microsoft products. And often, however, it seems that, at least in my experience, they don't learn what I want to do very often. And I have to expand the menu or turn off these cascading menus because what the next step I want to do often is not anticipated very well. So while that's an example of the concept overall, it's not an optimal implementation from my perspective, but there are a number of ways in which that can be made more effective. And then, of course, the application itself needs to work in a much more rapid fashion than historically has been the case for many of our transactional electronic health record systems. Here's an example of a view that we created using tools available from our electronic health record, but this was coded at Northwestern to interact with our electronic medical record database that we have. And what our intensive care unit physicians were interested in was very much something, at least in the transition period, off of paper-based flow sheets onto an electronic intensive care units, so that we were losing these paper-based flow sheets. we wanted to have really a representation of a lot of data that could be reviewed at a glance to understand some of the key elements. This is not yet completely optimized from a usability perspective, but I wanted to primarily show this as an example that there is a trend in the context of interoperability that many of our vendors are going to have to even become more engaged with to allow sites that at least have some degree of expertise to manipulate data and optimize it themselves. And this is, has both potential benefits to average users as well as potential harms if not implemented with usability factors in mind. So what I clearly recall a few years ago as we were proposing originally converting to electronic flow sheets within our intensive care units is one of our physicians at the time saying there's absolutely no way that he would ever practice in an intensive care unit setting where he had to review a flow sheet online. Well, what I think ultimately we've been able to achieve is a effective representation that can essentially be always available for patients in the intensive care unit that doesn't interfere with nursing workflow at the bedside and yet provides physicians with an always-on tool that continues to provide information with a view that the physicians have been accustomed to using. Ultimately, we're going to likely work to identify adverse trends and other areas to highlight here in an intensive care unit context. This is another screenshot of, again, a tool that's being used in the intensive care unit to highlight some of the trends, and it's a kind of a graphical tool. And in part, the reason for highlighting this is that, again, as our electronic health records are providing more hooks to manipulate information, we, at least at academic centers where we have some programming opportunities, can actually move in, manipulate some of this information, apply open standards tools to how we're going to display this data, ultimately work on usability, perhaps with partners such as User-centric, and then make this available also for electronic health records vendors to achieve. Many physicians work at multiple hospitals, especially in an intensive care unit context. The paper-based flow sheets have evolved over time to be somewhat similar. It would be great if we could have a similar electronic version that physicians would find both highly usable and highly effective for their ongoing care. Let's move to the other category. So that was, again, a bit about make me faster with some of the anticipatory elements, both for anticipatory information needs as well as anticipatory next steps that, from an electronic health records perspective, need to be in place for physicians to believe that the system is effective at achieving what they would like to do, efficient, and so that they can be satisfied, all attributes of usability. Now let's move to the Make Me Smarter category. There's a great deal of public discussion about health information exchanges and how, in the Chicago area, for example, we might have access to either University of Illinois, University of Chicago, Loyola content while a patient is admitted to the hospital at Northwestern. But what I can tell you is that when I'm taking care of a patient in the hospital at Northwestern who's had multiple hospitalizations here, it's hard for me even to dig through and find out what happened and all the key points on all those past hospitalizations here at Northwestern, let alone if I had the option to reach out to other medical centers or clinics where the patient might have been seen in the past few years throughout the region. So in terms of, and what I'd like to say is that within all of this content, for all of these hospitalizations, and potentially all of these external visits, there are buried nuggets of information that are extremely important about that patient. However, truly they're buried right now. A system that was usable from a fashion of teeing up important information that existed within the patient record would highlight these issues and make it extremely easy to access this relevant information. Turns out they're, from working with some of our Masters of Medical Informatics students, and in fact I have an ongoing project with one of them now, there really is a finite listing of these sorts of things that we'd like to identify, at least at a reasonable threshold level within the electronic medical record system. So while this sounds somewhat difficult, it probably isn't nearly as complex as one might think at first glance, and it's something that, from making the information usable to the physicians, is something our electronic health records vendors really need to focus on. Let's look at another category, interrupting real mistakes. The way much clinical decision support has evolved over time, there are certain triggers, and those triggers then prompt the appearance of an interruptive alert, which a physician will then interact with. What we have tried to do at Northwestern is to optimize the signal-to-noise ratio such that the majority of the time, if we are going to be interrupting a physician, that the physician ultimately changes his or her steps as a direct result of that interaction. And in fact, we further anticipate what those next steps are in the context of the alert, so one doesn't have to go elsewhere in the chart after receiving this sort of an alert. Classically, this hasn't always been the case. There have been a number of publications, which most of you in the audience are aware of, about this sort of a phenomenon. But what we also know is there are still many opportunities for still making dumb mistakes in an electronic medical record system that the parameters for which should clearly stop those at the get-go. If it's not something that's clearly wrong, however, for which the majority of the time, probably an alternative course of action should be undertaken, then a less overt signal should be generated that a physician can review at a time at which it makes sense within the physician's workflow. Along those same lines, the system needs to have inherent flexibility such that female patients shouldn't have recommendations that are present for male patients and vice versa. Order sets should be able to flex in such a way that if a patient has a contraindication to an item that exists within the order set, the automatically substituted item should appear. So a very clear-cut example there would be an allergy to a specific medication for which it happened to be included in an order set. When a physician might quite reasonably expect the system not to suggest that they use a medication, to which the system will then respond with an alert that the patient shouldn't have had this medication chosen because the patient, in fact, has an allergy to it. I know a number of our electronic medical records vendors are starting to implement this sort of functionality. In my mind, further work in this regard is an important element of usability of these systems, especially from an efficiency perspective. Another attribute of making these smarter is that, well, despite our efforts internally at healthcare organizations to convince physicians of the value of certain activities at a population level, in many cases they feel they could rely on their own memory to achieve a certain course of action, and they don't need the system to prompt them in that regard. What unfortunately we realize, however, is that memory is often fallible, and there are certain high-level quality indicators for which there really needs to be just a prescribed course of action that all care has to follow. Electronic health records can do this effectively. In many instances, at least for workflows that I've examined for how systems should currently be used, it's hard to implement this idea. In a clinical context, for example, would be effective risk assessment for deep venous clot prophylaxis and implementation of prophylaxis. So risk assessment and then ordering appropriate prophylaxis for patients. Performing a probabilist reconciliation at different points of a hospital stay, or a medication reconciliation at different points, different transition points. Topics of which, just judging by the audience response, you're likely, the majority of you are familiar with these issues. Well, many of the EHRs have implemented very nice, elegant processes for this, but effective integration into the workflow and or reintegration, should they be temporarily deferred, is something that in many instances often is lacking. and from an effectiveness perspective needs to be better addressed. In addition to the alerts that I was referring to about stopping me from doing something dumb, there are a number of instances in which there may be alternative diagnoses that perhaps I wish to consider, or algorithms that are seemingly appropriate to the patient I'm taking care of. Unless this sort of information is teed up for me in an anticipatory fashion, in the far majority of cases, also supported in the literature, physicians often fail to take advantage of the offerings that are available. One of the plans we have underway at Northwestern, or at least tentative plans at the moment, is to explore some of this unobtrusive assistance based upon patient characteristics with one or more of the content vendors for this sort of information for patient care. One example might be if one is taking care of a patient with a diversity of symptoms, that the potential rare explanations for things such as unusual poisonings could be teed up off to the side, available if the physician were interested to see a list of potential alternative explanations for what that patient has. Or, even perhaps a bit more futuristic in this regard, what were the diagnoses of similar patients like this in the medical center's own experience? And one could invoke this if interested off to the side, but otherwise this is the sort of information that one would not want to interrupt the physician about. Another example in this regard, and there are a number of tools that would address each of those examples I just gave. Another context would be when a patient has a low sodium value in the hospital, a not uncommon scenario. There is a very standards-based, consensus-driven algorithm for both the evaluation and subsequent treatment of that condition. Many hospitals that have implemented computerized physician order entry that may or may not even have order sets related to this evaluation and management, in which case those should be teed up for easy use as potentially appropriate for the patient one is now interacting with in the chart. Alternatively, external reference sources, perhaps linked directly to the clinical context for the patient, should be able to be teed up. From both an effectiveness perspective of doing the right thing in a standardized fashion for patients, and an efficiency perspective that otherwise physicians will never even bother to access many of these references and next steps. These need to be teed up effectively. It's rare that I've seen electronic health records that have been able to do this for more than one or two conditions, and in many cases not for any conditions unless there's a great deal of customized work. Actually, at this point, I'd like to put in a poll. And the poll here is, if you are a clinician using an EHR, although there aren't too many of those in our audience, or if you, I would change it a little bit, if you are working for a vendor in this regard, or even a consultant in this regard, have you heard this as a major issue, or have you personally experienced this if you happen to be a clinician? So yes, no, or not applicable. Again, alert fatigue as a potential concern. Okay. So can we make the response visible? Yeah, oh, there we go. Okay, for a lot of you, this wasn't an applicable question. For those of you for whom it was, there was a significant, more of you felt that this was a potential issue than not. My only thought is that if those of you haven't felt this to be a significant issue yet, either kudos for having made great decisions with your decision support implementation, or perhaps you haven't reached the point yet of enough people weighing in on this matter that to potentially water down a more rigorous approach to the signal-to-noise ratio. Let's just spend just another moment on decision support and related to automatically evolving order sets, related to automatic integration into workflow. I consider these to be effective examples of effective decision support in terms of making the right way, the easy way to affect patient care. Another context that's been discussed in the news a fair amount is the placing of radiology orders. One perspective might be, what are the pre-certification guidelines? Let's make sure that every T is crossed and I is dotted to make sure that we will receive appropriate reimbursement as an organization for the performance of this particular exam. So what some centers have performed, for example, is set up a few hoops that the ordering physician needs to go through in order to essentially justify the order from a billing pre-certification guideline. Another issue of decision support and monitoring effectively would be to make sure that is in fact the test that was ordered actually ultimately performed. But I would challenge us to think a bit more in terms of, is the right test for the patient being performed? And in fact, by right test was any test truly necessary? And then if so, was the right test actually performed? There have been some publications that have suggested for a population of 350 million or so in the United States that we are ordering 60 million CT scans. One might likely legitimately question whether or not all 60 million were truly required, not to mention the adverse consequences of CT scans from even radiation exposure at that high a population level, as well as subsequent testing to better evaluate incidental abnormalities that were detected in that fashion. When a CT is ordered, to think about it from a decision support context and how a system might interact with the physician, if a CT is being ordered for diagnostic purposes, as opposed to from monitoring purposes, which would have its own set of guidelines around it, and the frequency with which what's appropriate, what's inappropriate. So it's being ordered for diagnostic purposes. That essentially implies that the physician should have already assessed a pre-test probability that a particular condition exists for a patient before obtaining the test. As likely those of us on this conference call, but not necessarily everyone else is necessarily on the same page with yet, diagnostic tests merely move up or down a probability. It's relatively infrequent that a highly specific diagnosis is ascertained from the result of these tests. In other words, there isn't a 100% sensitive, 100% specific test for a particular condition in general, short of more invasive procedures that unfortunately often follow questionably diagnostic CT scan results. So if in fact this general order of treatment should proceed in this fashion, that is, an effective pretest probability for a particular condition exists in the clinician's mind, then it turns out for most of the modalities available for determining a diagnosis, a sensitivity and specificity exist for the test being considered, which leads to the availability of a negative and positive predictive value that the condition exists following either a positive or negative test result. Teeing these up explicitly to the caregiver before undertaking the ordering process, in many cases, will change the diagnostic approach. One additional example in this context would be where there's more of a focused diagnosis that I can describe here versus a CT, although I can give an example perhaps for diverticulitis or appendicitis, where there have been suggestions that ultrasound perhaps in many instances can serve as an effective emergency department modality initially, before the many CT scans that we're ordering in that context. Another area would be within diagnosing coronary artery disease, in which a pretest probability using any of a number of risk calculators that could be integrated within the record could assign a pretest probability that coronary disease exists. Once it's high enough, you're not gaining anything from even the most sophisticated stress test from a diagnostic perspective. There may be reasons for doing it from a prognostic perspective, but again, the evidence for prognostic information from the stress test in terms of how that affects patient outcomes is questionable. And in an era where we're looking to optimize the effectiveness of our healthcare dollars, this sort of information should be made much more visible to the physician at the time of ordering, is not routinely incorporated in our current electronic health records either from a functional perspective or an actual perspective, and is a direction where we need to go to ensure effectiveness of both decision support at the bedside and cost effectiveness of the healthcare that we're currently providing. Another big category I spoke about, in addition to the make me faster, make me smarter, is also the show me the data afterwards. This is just a slide describing a portion of the structure around our Northwestern Enterprise Data Warehouse, where we have our outpatient information with one electronic medical record system, our inpatient electronic medical record system from another system, combining at the patient level within our Enterprise Data Warehouse, as well as research data that's available. With all of this information, there's many opportunities for both operational reports, research and quality of care reports. One report that was an early request was from our intensive care unit. And from a usability perspective, this interacts in a to the topic at hand in kind of an interesting way. How we record information in an electronic medical record ultimately affects the usability of the content that we place there. Anything we put into an electronic medical record essentially is known at the time it's being entered by the person who's doing the entry of this information, but may or may not be optimized for retrieval by someone else who needs to access that information in the future. And this concept became clear as we sought to create an intensive care unit report for optimal management in that setting. First and foremost, we had a question, who really is an intensive care unit patient? The intensive care unit medical directors had clearly in mind a defined subset. The way in which the electronic medical record facilitated identification of these individuals and the way in which users interacted with the system was different from the way in which a medical director identified a particular patient in an ICU. The example here is that oftentimes patients may be transferred to an intensive care unit, but it takes some time for the patient to get into the intensive care unit. Then it turns out the intensive care unit desired doesn't have beds available, so the patient is only boarding in a separate unit, but is under the management of the other team. And then when the patient is ready to leave the intensive care unit and is stable, a bed may not be available outside the intensive care unit. The patient may exist again for a time in the intensive care unit, but not truly be an intensive care unit patient. So when is the patient an ICU patient applies? Why is the patient in the ICU is an issue that we also weren't capturing in a clearly identifiable manner. There's actually a finite, depending upon the groupers one has, and not very long list of true diagnoses for why the patient needs to move into an intensive care unit. And we weren't capturing this in a way in which it could be used downstream, even though from a usability perspective of just creating a note in that fashion, it might be helpful for the person at the point of care, but for subsequent use of this information, it wasn't entered in a usable manner. Further, there were some other key data and events that were required. So after a series of meetings, we were able to reach consensus on all of these questions, and now we have usable data, usable reports available for intensive care unit management. And these reports have helped us hone in on specific quality metrics for the right set of patients. Additionally, in the context of reporting, one area that in implementations that I'm aware of is often neglected at the get-go is ensuring, almost as a readiness factor for adoption of electronic health records, their meaningful use. I'm using these terms because there's obviously a lot of discussion about what constitutes meaningful use of an electronic health record. In terms of being able to use the data effectively, the right teams, personnel, manpower, staffing, finances around use of data need to be outlined before this sort of a system is implemented. Since we have these reporting capabilities becoming more and more part and parcel of the electronic health record itself, as the vendors are seeking to ensure that their systems meet meaningful use criteria, well, how are these reporting functions going to be implemented within an organization? Does the organization itself have the capability for managing this information, interacting, and launching a continuous quality improvement effort around these sorts of reports? Clear examples are missed EVT prophylaxis and blood clots, line infections that patients might have in the hospital, urinary catheters that need to be removed. In many instances, this sort of data will finally become transparent to organizations, but especially at community hospitals that are perhaps even less apt to have researchers involved with grant funding to start these up, or perhaps in smaller medical centers that really don't immediately have the funding, they may not allocate appropriately to manage this data out of the electronic health record effectively. And what I would challenge, especially the number of individuals we have from electronic health records on the call, is that they challenge their customers at the implementation stage to ensure that they have outlined staffing in an ongoing way to handle the output of these systems. Now, this is a challenge to the vendors, who are often challenged by their customers and prospective customers to show how they will have a return on investment for the implementation of their electronic health record, and are not often seeking to create new teams to act upon the information generated. So in many cases, and the people on this call know this better than I, there can be assessments of, well, what teams are currently in place? How are they using information now? Let's engage these teams early on to use this electronic reporting process instead, and to have as important milestones on the implementation path, improving these, making these reports available to these teams and converting them to their use. Or even at Northwestern, of examples that we have where people continue to follow paper-based, not truly paper, but individual chart-based reviews, when we could have, in fact, leveraged our enterprise data warehouse to review information for them much more effectively, but they've just continued to exist, continue to operate with the previous assumption of individual chart reviews are necessary. Here's an example, again, using a similar tool to what we leveraged to create our intensive care unit view. This is really the first of an evolving area of real-time quality reports that we intend to roll out. And right at the get-go, because we haven't had up until now a team devoted to running around the hospital and identifying patients who are missing prophylaxis against deep venous thromboses. We haven't had that team at Northwestern up to now. This is the one exception that I made, and that let's even create this report before we can even have the team identified to leverage it. We'll prioritize it highly, given its clinical care importance. And what anecdotally, what other medical centers have reported is that even by making this information available in a transparent fashion across the enterprise, they've actually been able to impact the completeness with which they are applying DVT prophylaxis. In part, what we found internally is that we've been able to identify risks appropriately, but we haven't always been consistent with the follow-through of applying the medication prophylaxis against deep venous thrombosis. So what this report that you're seeing provides, integrated in, is the first of a real-time quality report directly integrated into our electronic medical record system that, as of that moment, one clicks the report, takes about 20 seconds to load, but one can interact otherwise with the electronic health record while it's loading, is a survey of every single currently hospitalized patient and whether or not they are receiving deep venous thrombosis prophylaxis, whether or not they have an obvious contraindication, whether or not they have a stated contraindication to it, whether or not they have sequential compression devices, which are also partially at least effective against deep venous thrombosis. And then, if one were to click on the financial number, we're not making the patient medical record number or name visible broadly, but if one were to click on that, it then asks you your role in the patient's chart, and then you can click in and identify who the patient is specifically. If you click on the attending's name, it actually can send a text page directly to that attending. And what I'm very proud to mention is that now that we've made this report available, we have a team that has stepped up and is taking ownership of this for our organization real time. It's actually one of our pharmacy groups that will be monitoring this report, reviewing the chart with this information available already, and then contacting, when appropriate, the physician and letting us at the design side know how we can better tweak this report to further optimize its sensitivity and specificity to identify the right patient population missing prophylaxis against blood clots. At the end, we're going to have some time for questions as well. Just going to spend a moment again about the charts the way they are right now, the electronic medical records the way they exist, is that for the most part, they tend to follow a very conventional approach, reproducing paper chart sections in many cases. We have our online orders that drive our downstream processes, again with pretty rudimentary and generally interrupted decision support. And there's a often organizational perspective that it is the medical center's chart and not the patient's chart, as evidenced by our general reluctance within healthcare to provide inpatients complete access to their medical records and results as soon as they're available, and even our outpatient reluctance to provide complete, easy access to all information in the chart as soon as information is available. Now, granted, there are some complexities to that, but nevertheless, in principle, that, from my perspective, truly should be our goal. So what is missing along those lines, then, is it's really the patient's chart, doctor and hospital, and it's not your chart. This anticipatory support and guidance that we spoke about, that, again, there's generally a high-value, relatively short list of high-profile items to include in terms of anticipatory support and content grouping. Creating cockpit views that I'll talk a little bit more about. You saw the example for the intensive care unit, but I'll go through another couple of examples. Again, attempting not to interrupt the physician. And then, importantly, we don't really have a true problem-centered structure, which I'll talk some more about in a moment. At this point, let's go through another quick poll so that you can describe the areas that you feel health information technology, usability in particular, impacts the most. So does usability impact patient safety? Will it impact ultimately efficiency, data quality reporting, or pretty much all of them at a similarly high level? Okay, so you can see the results here, and that most of you are kind of sharing the perspective that I'm almost outlining here a little bit, that it tends to impact all of the above, even though we might think initially one area is truly physician efficiency, but ultimately making the data usable from the reporting perspective, this is going to have an impact there. From a patient safety perspective, for some of the reasons we discussed as well. So let me, at this point, move into some of the additional clinical examples here. I'll talk a bit about pushing to the right person actionable updates. And in terms of making information usable in the chart, it truly requires some degree of pushing rather than just making it visible. Again, one needs to be judicious in the application of this approach. That the problem list, which I have already briefly alluded to, ultimately needs to be a core that we build upon for patient care. We need better to reveal hidden content that I've discussed, the cockpits as well. I'll go over hospital admission process briefly, med-rec briefly, sign out, and discharge. Let's talk about pushing actionable updates, and I'll give you some examples of what we're doing here at Northwestern. If one of my patients comes into the emergency room, I'd like to be notified when they come in. And what we've done in this fashion is we have enabled a way in which information can either be automatically paged to a primary care physician and or sent to an electronic in-basket. In addition to coming into the emergency department, where I watch electronically as the care evolves, interestingly, for those of you from health record vendors, we do this effectively across electronic health records, where the patient has documentation in one system and I'm watching the documentation evolve directly in my in-basket of another electronic medical record system. So we can do this across systems. There's with some internal development that we've had to do to identify these patients. This is something that clearly should be part and parcel of each individual vendors or organizations that have a less complex implementation and with just a single vendor should be able to leverage. Then additionally, if a patient is admitted, there should be communication. If the patient has a step up in care, there should similarly be notification, and there should be an assurance of closing the loop should a patient expire during the hospitalization in some way, so that the outpatient physician isn't misled by what might be happening. From a patient safety perspective, it's well acknowledged that any sort of a transition in care into the inpatient side, across services, and then a discharge are very vulnerable states for the patient that things may be missed. One initiative, again, across electronic health record vendors that with some effort we were ultimately able to put together is if one of my patients is discharged from the emergency department setting or is discharged from the hospital and has results pending at that moment, that any pending results will come to me as the primary care physician for that patient once they are finalized. And this has been enormously helpful. It's also been reported in literature to be a major patient safety hole. And from medical centers that I talk to that have single vendor systems in place, this is infrequently implemented at their locations because it requires a fair amount of customization even within their single vendor system. In terms of making the data usable to the physicians, this is a clear example of where we need to be pushing data to the right individual. And one other highlight to note is, well, how does either of our systems know I'm the primary care physician for this particular patient? Turns out the way we've implemented our system is we take the union of these sets. So if our inpatient system lists me as a primary care physician or my outpatient system lists me as the primary care physician, I'm going to receive results for that patient. Or if different physicians are listed in each category, both physicians will receive this transition information for when the results become finalized after that transition of care occurred. The bullet where I mentioned here, what is the definition of a primary care physician, is also something ultimately that even internally within organizations one will have to discuss a bit. The reason for this is once we have this sort of a system in place, we can actually push any sort of content to the primary care doctor. We can also very easily overwhelm primary care physicians. I'm aware of primary care physicians who want to receive every single update about their patients at all times for a very defined panel of patients that they care for. Because those physicians who do that, without exceptions, those that I'm aware of, are only working part-time in an ambulatory context with a more manageable subset of patients than perhaps 3,000 patients, for which if all results at all times were available, could easily be overwhelming. Nevertheless, there are certain results that one might agree as an organization primary care physicians should always see. These sorts of care transitions, for example, would likely be at the top of that sort of a list. Quite obviously, with our work on DVTs and additional work here, we're far from optimized from where many of us feel Northwestern needs to be. One additional area in this category is there are other interested physicians on. And the way we deploy this initially, it's really only the primary care physician who receives this information. We're looking for ways now to expand this for easy self-selection by other kind of continuity physicians who are very interested in receiving updates to which they can temporarily subscribe for that patient over time and then unsubscribe when they feel they no longer need to see all the information. A very obvious scenario in this regard is patients have procedures performed. And should any sort of potential complication arise from that procedure, the person who performed the procedure should receive immediate notification so that they can assist in that patient's management. They want to know about it, and there's definitely examples for which they are not contacted. Letting or creating an automatic temporary subscription to that patient in some regard would greatly help from a effectiveness, efficiency, and safety perspective for these patients. Let's talk for a moment about the problem list core. The vendors that I'm in touch with on a regular basis clearly are starting to move more towards towards increasing the prominence of the problem list in the electronic medical record. And in part, historically, there's been some constraint from a physician readiness perspective to adopt this sort of a model. At the same time, my contention is if an effective and efficient workflow were created, physicians would tend to gravitate towards its use beyond what they've historically followed, which is really a chart siloed within individual progress notes with essentially an orphaned problem list that may or may not be routinely updated with relevant information. So my contention here from making the chart usable perspective is we need to beef up the heart of the chart, which truly is the problem list. And the way I would describe the problem list would be a specific representation of ongoing clinical concerns intended to facilitate effective longitudinal management. The word specific is important because we want to hone in on precisely what's going on as opposed to just a cardiac problem, the fact that it is systolic heart failure that exists, perhaps even the grade of that heart failure in some fashion. And then by mentioning ongoing clinical concerns, this should be used to, it should be a live, evolving list based upon how the patient's doing. And then to facilitate effective management, this needs to be incorporated truly into the workflow and essentially facilitate workflow for management of these issues. Versus what I would call the separate category of the past medical history, which is essentially items in the past, which by virtue of being isolated are just isolated events that one still wants to have a record of that can exist, but is not used in a way for effective longitudinal management of ongoing concerns. So how do we do this? How do we integrate problem lists effectively? There are a couple approaches here. One is that in an unobtrusive way, after notes are created, And there are several systems that have evolved from a number of different vendors, including some of the electronic medical records vendors, to look into content in the chart and tee up potential items. Rather than relegating this to a research context or a coding context, this is my plea, in a sense, to the members of this audience to make a chart usable, to work at leveraging these sorts of tools in real time to facilitate physicians adding items to the problem list that otherwise might have been missed. And this dovetails well with revealing items buried within the chart. Then let's assume we have a list that includes some specific items that need to be tracked longitudinally. Well, for each individual item on a problem list, you can pick an easy example of diabetes or heart failure or coronary artery disease. There are certain relevant historical items, either diagnostic test results, laboratory test results, medications, that are tied to these. Some vendors are just getting to the point of linking these. This is a topic I've talked about for a long time, and I'm happy to hear that some of the vendors are starting to do this, but we haven't gone that far yet. Clearly across vendors, or in a way in which it's well integrated into workflow. And that is automatically making this information visible in a problem context. So when one is looking at a specific problem, this information should be automatically teed up in a fashion at which it lends itself to easy interpretation, and then from an anticipatory decision support and guidance perspective, as I discussed earlier, the next step actions that are likely available for that particular problem. And for each of these problems I mentioned, there's usually only a handful of typical things you might want to do for those issues. You shouldn't have to then leave that context and find those issues again. They should be teed up and directly available in the context of those issues as well when those steps were last performed. If we don't incorporate this effectively, along the lines of my orphan quotation mark there that apparently I left, the problem list becomes its own orphan in the medical record chart. It's not managed effectively, and again, we continue to perpetuate silos in the chart. We need to integrate the problem list as the heart of the chart, and in fact, the way in which we interact with the chart through the problem list. And there have been a number of people who suggested perhaps even using real-time updates to each of the problems so that at a glance, everyone knows what is the current state of management, current state of thinking for the caregivers for this particular problem, with more like a Twitter-like update. Currently, in a hospitalized patient context, an update in the chart is made once a day by a physician, and that note sits despite the availability of a great deal more information until the end of the following day when one subsequent update is there. In the current rapid change environment, rapid pace environment of a hospital, when much information becomes available throughout the day and steps are being taken, it likely makes more sense to facilitate easy, rapid documentation throughout the day, while still then at the end of the day, from a billing perspective, which physicians often then mention as a concern with evolving our documentation paradigm, our electronic health records vendors should easily be able to assimilate this content into a note from the billing perspective. But from an ongoing care management perspective, this paradigm no longer seems to reflect the care environment. Spoke already a little bit about the revealing the hidden content in the context of the health information exchanges, let alone finding our own information. But there's a lot of obvious content that exists. Missed appointments, missed tests that patients should have had. Teeing these up for easy visibility in the chart to discuss with the patient, understand the issues. And in many cases, missed tests may no longer need to be performed because the passage of time has revealed that, well, it obviously was nothing to be concerned about because another year has gone by and nothing has clinically progressed. But at the same time, in some instances, it would be important to follow up on some of these diagnostic tests if there is a specific concern in the past that, in fact, what is the type of sickle cell disease that this patient has? Perhaps hemoglobin electrophoresis should be performed that was ordered, never performed. Or there may be an abnormality that surfaced, an incidental renal abnormality that was at a threshold for which additional diagnostic testing was clearly advised and no further imaging or testing had ultimately occurred. Now, this is a controversial question in of itself, but we do have thresholds set for when these incidental abnormalities are identified and whether they should be followed up. Another example here in the past would have been an episode of acute renal failure that a patient experienced, which would make them more susceptible for future episodes of acute renal failure, even though, if not identified in the chart, one might have a lower threshold for potential application of toxic medications than one might otherwise have should one be aware that this patient, in fact, had acute renal failure from multiple causes in the past. Again, this revealing hidden content, the problem list is an appropriate venue for revealing some of these issues, or perhaps we can identify a new category of perhaps care gaps, as some clinicians have described them, or just a general loose ends category that needs to be acknowledged by caregivers for the patients to make sure that we're not missing these items. In terms of designing, creating cockpits, cockpit views, infectious diseases is an interesting area in that for patients who've been admitted for multiple weeks in the hospital and have had several complications along the way, the primary teams, even speaking for myself, are often always have multiple reasons for consulting infectious diseases, one of which is even to sort out the information effectively to understand what the next steps are. When patients receive multiple antibiotics, multiple cultures, several positive at different times, different potential sites of infection, it's hard to make heads or tails of this information conventionally the way it's displayed in electronic medical record systems. Creating a timeline-based view is something that some of the vendors are starting to work on. This sort of an idea lends itself to multiple areas, not only infectious diseases, but perhaps cardiology, rheumatology, others, to show what was the clinical state of the patient at a given time, what were some of the key physical exam findings, what were some of the key diagnostic test results along that timeline so that one at the moment can make the best decisions for caring for that patient. And in many instances, for example, in an infectious disease context, turns out their recommendation is stop all antibiotics. This patient actually had enough antibiotics for conditions A, B, and C during the hospital stay. This last culture is still likely a contaminant, and let's stop all antibiotics. And that is not infrequently a recommendation. If this information needs to be more transparent in the chart, otherwise, in many cases, physicians tend to err on what they feel is the conservative side of continuing antibiotics in that particular example. However, issues of increasing antimicrobial resistance to broad-spectrum antibiotics, as well as antibiotic-associated diarrhea are increasing phenomena. A couple of more final clinical examples here to leave a few minutes for questions here. Hospital admission, key process to integrate into the workflow effectively all communication about this patient. For information to be usable, new information arises, the nurse needs to know who to contact, other physicians need to know which physician to contact. This needs to be well integrated into native functionality within electronic medical record systems. Again, ensuring the problems meds are captured, perhaps either via decision support, teeing them up, and a number of centers have published on this, but hasn't been routinely incorporated. And then all the organizational priority areas need to be addressed. And this is where leveraging that workflow effectively is key. Med reconciliation, actually in the interest of time, I'll just skip over this quickly, but knowing all the medications obviously is an important patient safety feature. Sign-outs are again a transition point. A number of organizations, I have heard, have house staff that on occasion even use Google Documents, unfortunately, in a non-secure fashion to store some sign-out information. It's easy to use, it's collaborative, easy updated, everybody has easy access to it. This sort of feature is something clearly our electronic health records need to adopt, improve these transitions of care effectively, how to make it easier than these other inappropriate systems, no reentry, address specialty needs that are going to vary, automatic incorporation of updates within, well, incorporate updates from the caregivers integrated with their workflow, and then automatic inclusion of standard information that an organization feels needs to be addressed at the time of sign-up. And then discharge, many of the same factors identified at admission and sign-out are applicable at the discharge context as well, including, as I highlighted, at pending results. And I think we have one more poll. Quickly, and then I'll some questions here. So, and this is a general question about usability. How would you relate usability and workflow? These are related concepts with the potential for having some degree of overlap here. It's also possible we were going to revise this we hadn't for kind of both of these potentially would be applicable. But that's fine. So let's see. A usable electronic health record interface supports efficient and effective workflow. So some of you also, as I feel pretty much both of these apply, so it's a little bit of a split here, but in terms of emphasizing here, yes, we need it to be usable to support the efficient and effective workflow. Workflow itself makes it easier for the clinicians here. So let's see my conclusion where I summarize these concepts a little bit as well. So for physicians, usability implies understanding information needs for effective decision making from my perspective. So we need to really understand how this information is being used, what the next steps are, and then from a health record design perspective, we can make that information available in that usable fashion. So here, anticipating the array of information required to make informed decisions and the array of options available, again, as I've mentioned, finite and short, at least at a first branching level, should render the health record systems much more usable from a doctor's perspective than they currently appear. And with that, let me open it up for a few minutes of questions. And also, I'd like to just invite people, you can email me with follow-up questions as well. So my email address is posted here on this last slide.
All right, thank you, Dr. Leibovitz. We have a bunch of questions here from the audience. One of them is, why do IT offload reports to RNs? It seems to me the reports should be part of the system. It sounds like you have the right players.
So, great question. And what I would suggest is that the here's what we've tried to do at Northwestern. In the areas that are invested in looking at the data with a critical eye, we've attempted to identify individuals who can actually create reports. And we provided them with access to our enterprise data warehouse because we want them to be innovative in terms of thinking of all the measures they might want to identify and create those reports themselves. So to a certain extent, we want to give the tools in an easy-to-use way so that clinical areas can start creating their own reports and hone in on those areas they feel are most effective and then carry them forward.
Great, thank you. Second question, how could Northwestern work with and partner with their EHR vendor to evaluate and improve the usability of their systems? Do you feel it's possible to improve, and what are a few things that could be done today?
So, absolutely. We are interested in partnering with our vendors, and I'm not sure if that came from one of our vendors as well. We don't know. But we attempt to work closely with our electronic medical record vendors. And for any of you specifically who know you work with us, feel free to email me after this call. And I think there are a number of collaborative opportunities. We have a development team both in our outpatient practice and in our inpatient practice who would be interested, willing, and able to integrate some innovative experiences in usability to study this issue jointly with you.
Great. Do you see many university-based health systems conducting formal user research with EHRs and other technologies to help patients?
Actually, I don't. From my interaction with other chief medical information officers, I think I've only heard of spotty work in this area, but it's clearly an issue. And for example, the Society of Hospital Medicine has emphasized usability in and of itself as something that's of extreme importance in working to get members to kind of convey concerns to the vendors specifically, but in terms of academic organizations, singly working with them, not that I'm directly aware of.
Okay. Last question here, is your EHR part of your simulation labs?
Great question. Yes and no. So what I would say is that we have multiple areas of simulation at Northwestern and expansion plans underway as well. So many of them are procedure focused, and to fully encompass timeouts effectively for period procedural documentation, we are planning to, but haven't yet, fully included electronic medical records in those settings. We also have observed structured exams that students and sub-residents are going through, and in that context, we are seeking, we've embedded in a limited way some electronic medical record usage. We're actually seeking to do this more. So actually, for those of you interested in, if you perhaps, whether or not your vendor Northwestern's using or not, but interested in partnering in a simulation lab that we are looking to expand, I'd be happy to put you perhaps in touch with some of the people who are working in that regard, because that is something we seek to achieve with better integration of SimLab. We're doing it to a limited extent right now.
Great. Thank you very much, Dr. Leibovitz, for this great presentation. If anybody else has any follow-up questions, again, you can email Dr. Leibovitz directly, or you can also email hitusability@usercentric.com, and we can forward those questions as well. On the screen there, it shows our series in total, and the last one highlighted there at the bottom is next Thursday. So go to usercentric.com /HITusability to register for that last seminar there. Thank you very much, and you'll be receiving